Hello, everyone, and welcome back to another episode of the Warriors of Wellbeing podcast. I'm your host, Mike Beverly, and today we have Dr. Sasha Blaskovic, known to his patients as Dr. B. He's a distinguished chiropractic doctor specializing in head and neck injuries and drawing from over 20 years of experience, which includes over a decade of playing football and treating injured patients. Dr. B possesses comprehensive firsthand knowledge of mild traumatic brain injuries and whiplash-induced neck injuries. So welcome to the Warriors of Wellbeing, Dr. B.
Thanks for having me, Mike. It's a pleasure.
Well, I know as you and I initially met, you told me a little bit of the story of how chiropractic came into your life and how it is your life now. So do you mind sharing that with our listeners?
Sure, yeah. When I was between the ages of 10 to 12, chiropractic was something that I wanted to do because of a hip problem that I was having that would render my one leg completely numb and useless and weak. And a chiropractor helped me out of that. And at the age of 12, which was 2 years into this problem, when I finally got fixed by this, I set my path to become a chiropractor. And not knowing that I would go through the preliminaries at university and play football there, which, by the way, I was told I wasn't going to be able to do because my muscles were too weak. And however, this chiropractor proved all those doctors wrong that fixed me. And I sustained what was deemed a concussion back then in university playing football. And fast forward, because I had the backing of chiropractic training and chiropractic education, which is heavily biomechanically oriented, it gave me the ability to use the platforms that are out there and available for learning and researching something that's not concisely compiled in any curriculum. And that, to say, is the problem that I was left with after that so-called concussion, which is permanently damaged or permanently torn ligaments in my upper neck, which left my top two vertebrae moving too much in relation to each other, which one can construe as instability. And then that instability, what it does is it allows those vertebrae to mildly nudge up against my brainstem on a repeated basis, which is what actually gives me the mild traumatic brain injury or post-concussive like symptoms that come and go and have been persistent for the last 24 years to some level. That's pretty much it in a nutshell. And being a chiropractor, it gave me the ability to know where to research to be able to find out how this all pieces together, what my injury is, how it affects my neurology, and how my neuromuscular system tries to mitigate so that I have less symptoms. And it's a really fascinating and just a wondrous um, compiling of creation that it blows my mind how wonderful it is, but yet how debilitating it can be for most people living with this. So I've dedicated my career to learning as much as possible about this, because I've only tipped the tip of the iceberg here, but yet I already know quite a bit to be able to help people like myself.
That is so interesting how you do a certain amount of study and you go, oh my goodness, I didn't know I would discover that. And it's amazing. I was doing a little research on Google Scholar this morning on some chronic pain and inflammation topics. And I go, oh my goodness, something new. And so it's if people are open-minded and curious about different topics, there's so much information out there, and that's amazing that as long as you've been in practice, you're continuing to learn.
I am, and I find that the disconnect is I think not that the information is not out there, but that the curiosity doesn't seem to be piqued by with other medical professionals, which would then allow them to ask themselves, this doesn't make sense. For example, the simplest example I can give you is most of the patients that either come to me personally or that I help virtually, if they're in um, Egypt or South Africa, or people from all over the world will contact me asking me to look at their medical imaging, so their MRIs, CT scans, X-rays, which were reported on as unremarkable or normal. And yet when I look at them, I can pick out these nuggets that are basically indicators of these people having sustained ligament damage in their upper neck, usually, which would explain all of their neurological symptoms that they have that are, vagus nerve related symptoms that would fit into all the categories of what mild traumatic brain injury has been defined as. And I would, argue to say that the true diagnosis shouldn't be mild traumatic brain injury, but should be mild traumatic brainstem irritation due to an unstable cervical spine, with the actual, causal link being permanently torn and damaged ligament structures. And it is fascinating.
That certainly is. And you mentioned the vagus nerve, and that's something that, and speaking to me, someone who was a musician and music teacher, who I had to take one science elective in college to get my bachelor's of music education. And I hated biology and barely got a D so I could pass and get the credit. But so ever since I went through my near-death experience and challenge in 2020, I have been so consumed with learning. And I went to the chiropractic convention. It was the national one, but it was held here in Florida about 6-7 months ago. And the gentleman from Canada, he's a chiropractor and a research scientist from Canada, wrote a book about the vagus nerve. I was trying to look at the title of it. You probably know who I'm speaking of.
I actually wrote a book on the vagus nerve as well. It was just published last year.
Oh, really? Okay. Okay.
Yeah.
Well, I'll have to look that up. And we had him scheduled to be on the podcast as well. And then it seemed like the whole family came down with COVID. And
Yeah.
so the recording session we had scheduled for him, he was really under the weather with it. So any rate, we never were able to do it, but he said he will do it. And that's really cool. But the vagus nerve is an amazing part
Yeah,
of.
if you just Google what the vagus nerve does and you then correlate that to what, people deem a mild traumatic brain injury or concussion, you could pretty much overlay those two and
Yeah.
see the same thing. And so diagnostics is really important. And like I said, when the imaging reports come back as unremarkable or normal, but yet the physician that is dealing with this type of a patient is hearing them list all the vagus nerve type symptoms that they are having, I think all it takes is just observing and listening. And I think, unfortunately, that disconnect is there more often than not, where the doctor goes off of the radiology reports and says, well, you're talking about all this stuff, but yet the radiology report shows normal or has been reported on as unremarkable, and then completely, forgetting about the fact that the individual just talked about dizziness, nausea, blurry vision, balance and coordination issues, heart palpitations, temperature control issues, urinary and bowel issues. So all those things kind of get put to the side, and the imaging report is the thing that gets, focused on. See, everything's normal, so you might be, you might be depressed or something. Let's give you some antidepressants, and not really trying to pay attention to what could be, what one thing could be responsible for all those different body systems having a malfunction or a disconnect at the same time. And it's rare, virtually impossible, that all those systems at the same time would have something going on with them because of the system itself, where it would be much more logical to think, well, what centrally governs all those systems, and let's look there. And it turns out that the answer tends to be there, more often than not, if not almost nearly every time, that there's something going on in that region of the upper neck that points you in the direction of, well, this is what's causing those symptoms.
That is so amazing as you were describing how things come back. And I support and am a contributor to several groups on Facebook dealing with chronic pain and inflammation. And before I became a contributor, I was just reading the feed, people posting in there, and they go, I told them I had this, I told them I had that. And they said, oh no, you need this, or you may be depressed, and so on and so forth. And it's like everything you just described, I kept reading over and over and over again in these groups. And it's like, and one of the things that I had to share with a lady I spoke with, I said, look, until I spoke with a chiropractor and an integrative medicine specialist, I didn't get anybody to listen to me. I would say this or I'd say that, and they'd say, oh, well, because you've had this issue, you should be taking this instead of listening to what I'm saying. And so obviously that is a big part of your protocol, is probably just listening, right?
Well, yeah, the focus should be forensics. The focus should not be listening to symptoms and picking off the shelf or out of a book which thing would block that sensation or that symptom. Because if you're just looking at something that's going to deal with the symptom, and I, beat a dead horse to death with this, but you have to listen to the symptoms to be able to try to forensically decide, well, what would be causing all those symptoms? Instead of, we've got dizziness, let's give you anti-dizziness. We've got nausea, let's give you anti-nausea. As opposed to seeing, well, what one thing or what, few things might be contributory to having all those symptoms occur, and then trying to forensically decide, well, let's go look there. And then when you go look there, if you find something, don't dismiss it as, oh, it's just a coincidence, or sometimes what I'll even see in reports, this is a normal variant, which then is the radiologist pretty much kiboshing a person's case and their ability to get direction with their problem, because they're unilaterally deciding that something is a normal anatomic variant, as opposed to saying, this might be something of concern if the patient has X, Y, and Z symptoms. And in the requisitions, oftentimes the symptoms aren't listed out. They might just label it as a post concussive syndrome or whatever else, as opposed to listing out the dizziness, nausea, heart palpitations, all those things, so that the radiologists have a little bit more to work with.
That's very interesting, and I am thankful, and I know your patients are, that you're that thorough.
Well, I mean, if I was a patient, that's what I'd want, and that's sort of, I put myself in their shoes every time I have somebody come in. Is if I'm the person, or if I'm the parent of such a person, what would I want to get out of this? And I wouldn't want to get out of this some vague random symptom reducing technology. I'd want to either have an answer or to be guided to somebody who could potentially provide an answer. And so I'm not all knowing and all capable. And so if I am limited by what I'm able to do for somebody, I'll do, my darndest to find somebody that I can refer them on to, who might be able to shed some light on the thing that I have very little experience or no experience in. And so that should be the focus of every physician, is to either solve the problem or to find somebody who could potentially solve the problem that they can't.
That's really outstanding. Well, I was noticing in your bio that not only do you have offices in Langley, BC, Canada, but Linden, Washington, and in Rotterdam, Netherlands.
Just outside of Rotterdam, yeah. About 20 miles roughly southwest of Rotterdam, yeah.
Okay. So how did that all come about?
Well, we actually lived in the Netherlands for roughly 9 years at the beginning. So 2002 to 2010-ish, or 2001 to 2010-ish. And so we had we had a clinic there. And what ended up actually happening is we wanted to utilize this special imaging technology that I'm now utilizing both in Langley and in Linden. And I purchased said machine back in 2007, at the beginning of 2007, but unfortunately that technology was not able to get into Europe. And my understanding is to this day still not able to, for various reasons. And so what that ended up doing is taking us out of the Netherlands and back to North America, where we could utilize this specialized, what's called a motion X-ray. So basically, when you're trying to diagnose whether somebody's got an unstable neck, you can't assess them in a static neutral position. You have to challenge them through their full range of motion in all three planes of capable motion, to be able to follow and look at the bones as they're shifting, which they shouldn't be relative to each other, and then measuring how much they're shifting to determine the severity of the damaged ligaments. But that's kind of what brought us back to North America. And otherwise, we would have potentially even still been in the Netherlands, because I mean, there's not a day that goes by now that it doesn't surprise me or doesn't shock me how prevalent this problem is. It's far more prevalent to some varying degree all around the world. Like I said, people from Tasmania, from Australia, from Africa, from Egypt, from other parts of Europe, Germany, Sweden. They'll contact me, and these problems are prevalent everywhere, and they're much more common than I ever imagined. And again, in different varying degrees of severity. And it's the same triage everywhere. If something is not seen on the brain, like a brain plaque or a stroke or something like that, these people are told they have no problems, but yet they continue to manifest all these vaguely mediated symptoms that are destroying their lives. And I've even had some cases of people who were scheduled to be put down, basically, and assisted suicide to relinquish living with these problems. And then other people who I've had who were diagnosed with something like ALS or MS, that we come, discover the core of their injury or their problem turns out to be an injury, and we, refer them off for neurosurgery, and all of a sudden they go from being an ALS patient to being perfectly normal. And so, the brainstem region is so intricately sensitive and so intricately involved in all bodily function that if something is going on there, you could have a whole gamut of problems that could be labeled, like I said, ALS, MS, Parkinson's, whatever, that aren't possibly truly those conditions, but are a version of the manifestation of the unstable upper cervical spine irritating some part of the brainstem. And whatever part it irritates and to what severity and what level, you will manifest those symptoms. And unfortunately, once people have been diagnosed with any one of those named conditions, the system tends to want to palliate them and make their lives more comfortable, as opposed to reversing and going, well, what could possibly be causing this? Let's go try to dig some more. And they don't know where to dig because they're so used to, palliating and triaging symptoms and trying to make people's lives more comfortable, that they've accepted, like the system, I'm saying, has accepted the fact that, these diagnoses come by way of environmental conditions, genetic conditions, um, post-viral conditions. So those are the three major, what they believe are causes of all these things. And that might be very well so, but I think there's this component of past injuries coming back to haunt you. If the brainstem is repeatedly irritated and bumped up against by the first cervical vertebra over the course of years and decades, you could develop a chronic neurodegenerative condition. And I believe that is a possibility for some of the patients out there who have these diagnoses.
That's interesting. Now, this technology that you mentioned where you can, x-ray people in there while they're in motion,
Yeah.
is that being prominently used in the US and Canada currently?
Well, in Canada, there are only two systems of this like that are being used. One in our clinic and one out in the east in Ontario. And in the States, actually, there's a third machine, I believe, in Canada, but it's been recommissioned to be used for barium swallows, because you can actually also see when you swallow a barium-laden liquid, how it goes down your esophagus and whether or not your stomach has a herniation or there's something going on in the upper part of the digestive tract. So it's being used for that, and my machine and then the one out in Ontario are being used to diagnose patients like myself. And as far as the states, there are multiple machines all across the states. I would probably say a few dozen of them. Yeah.
That's it. Just a
Yeah.
few
Yeah.
dozen.
Yeah. I mean, ultimately, if you look at it, the majority of these machines are being used by chiropractors. And so the manual medicine that we as chiropractors are taught to practice is looking for restrictions in motion. So when you're utilizing this technology, you're actually finding excesses in motion as opposed to restrictions in motion. So it technically, unless you're using a technique like I use, which is non-adjustive, I'm not trying to force anything back into position. I use a neuromuscular technique called pneumoreceptor tonus. So unless the chiropractor is using that kind of a technique that addresses the neuromuscular facilitation systems, and you're focusing on adjusting somebody, it's hard to justify adjusting unstable joints. And so there's not a lot of utility for most chiropractors to use this, because it doesn't help them justify the work that they're doing. And so the select few of us that are out there doing this, we understand this component of instability, and we have molded our practices and our techniques to accommodate for that type of a pathology, as opposed to something that is not moving too much and just adjusting it.
Wow. So now, do you own the technology or the rights to it, or this?
No, it's open technology. I mean, I mean, there are companies that make machines, and they don't really own anything other than their own brand. But it's basically fluoroscopy, which is basically, most hospitals have a fluoroscopy machine or several fluoroscopy machines, that they use procedurally. What I mean by that is they will use it to make sure that their prosthetic implant is in the right position, or if they're doing a biopsy, that it's in the proper position, so they can watch real time as the surgeon is fishing to get into the right spot. And it's used for example, pain injections, so that they can localize and ensure that they're in the right spot at the right time. So they're not being generally used diagnostically. They're being used procedurally. And so these machines are very similar to those fluoroscopy machines in hospitals used procedurally, but they've been retrofitted and tweaked on several levels to be able to become diagnostic utility as opposed to procedural utility.
What's amazing to me, in the last year, I've heard of multiple situations where people have ALS.
Mm-hmm.
And I was at a wellness conference last Saturday in North Carolina, and a lady said, "Oh, this is why she's not here attending, because her husband now has ALS and they're, getting him ready for hospice care." And so, but I mean, it seems like in the last year or two, I've heard of more and more cases like that.
Yeah, I mean, there is a demographic right now that is being researched, and that's the long COVID patient group.
Mm-hmm.
For some reason, there appears to be some linkage between the long COVID and somehow affecting the connective tissues. For example, uh, I would assume I would list the long COVID as a chronic inflammatory condition.
Mm-hmm.
So if you look at something like lupus, especially like rheumatoid arthritis, those types of chronic inflammatory autoimmune conditions, if you will, they have a propensity to attack connective tissue structures. And in the case of rheumatoid arthritis, that's probably one of the most well-studied groups of individuals. The propensity for the rheumatoid inflammatory process to affect the ligaments between C1 and C2, so the upper cervical ligaments, is quite high. So that is the one group of people that have been studied as far as having C1, C2 instability that is non-fracture connected. And so a lot of people, I'm seeing a lot of people now that have been diagnosed with either long COVID, which then comes paired with other diagnoses that are just describing, again, their presentation, such as chronic fatigue syndrome, dysautonomia, which means there's something going, haywire with their autonomic nervous system, so it's dysfunctioning. Or people will get labeled or diagnosed with POTS, which really, again, doesn't tell you what they have. It just tells you the symptoms. So postural or orthostatic tachycardia syndrome, which means that their heart races when they go upright. And so all those different labels are showing up, having evidence, once we do the imaging, of an unstable upper cervical spine. And so is it inflammatory? Is it traumatic? Is it genetic? Is it environmental? Or is it a combination sometimes of all those things? But at the end of the day, whatever it is, if they should show to have instability in their upper neck, it is irritating their brainstem because of the symptoms that they're experiencing. And so at the end of the day, the question should be, what do we do? Do we try to conservatively manage these people by addressing their neuromuscular system by techniques such as the one I employ, or is it severe enough that and they're disabled enough that it would warrant considering neurosurgical fixation or fusion of C1, C2, whereby an instability goes into immobility. So basically C1, C2 become one bone, and there's no more moving around and sloshing around and bumping of the brainstem. And so generally that's sort of what happened with the ALS case in particular that I'm talking about. Is there was gross instability up there, and he was accepted for neurosurgery, had his surgery, and literally went from wheelchair bound and having to walk around with help, and being a really frail, skinny individual, to walking the streets 2 days after his operation and regaining his life back. So was it ALS? Maybe. Was it this being labeled as ALS? Possibly. But at the end of the day, we diagnosed instability with the machine. We validated the ligament, the proposed damaged ligaments with a specialized MRI, and that qualified for surgery. And then the patient now has regained a large proportion of what was their life before.
Wow, that has to be so gratifying to know that you played a small part or
It's humbling. And, I think that anybody who has either an MS diagnosis or an ALS diagnosis, it should be well within their desire pattern to see if they have C1, C2 instability. Because if that is the case, I mean, for example, in the case of an ALS, which is much more of a your fate is sealed and it's just a matter of time. What does the person have to lose in that scenario if they have objectified instability at C1, C2? What do they have to lose in getting surgical fusion of that? The worst thing that could happen is that they could actually get better. And the inevitable outcome is the inevitable outcome that everybody's expecting is going to happen at some point in time. It affects the nervous system. And at some point in time, your diaphragm can't go up and down anymore because it's affected it to that point. You can't breathe anymore. And that's it. And so instead of palliating, and I'm not saying that that's not necessary in a lot of cases, but instead of, determining that that's the course, let's just make this person comfortable and get them the proper wheelchair, the proper computer that can read their mind, and they can communicate and all that stuff. Should they have instability, at the beginning stages of being diagnosed with this, what have they got to lose? Because at the end of the day, their fate, so to speak, is decided and sealed, and this might provide a reversal of that.
yeah, what an amazing blessing that could be for folks. So do you do this movement X-ray on the average patient that's not exhibiting any of those potential? It doesn't, you don't do it for the average?
No, there's no indication for it. I mean, if somebody really wants to see what their neck looks like when it's moving, and they have neck pain, I will generally try to talk them out of it because it is not relevant for helping them better. And I don't think I've ever actually done one for somebody just because they were curious. Most of the people, like I said, that come, they're, I mean, if you spend a day in one of our clinics, you'll see how blessed you are to be as dysfunctional as you are, because there's a people that are a lot worse than you and I walking around that are not getting any assistance. And so there's a lot of people that would qualify for it, but the average person, it's not of any benefit to them, especially if they're not, I would say if they're having dizziness, nausea, headaches, blurry vision, occasional heart palpitations, temperature control issues, balance and coordination, any collection of those, digestive, I would say it's a strong indication whether they can remember that they've had an injury. Because I have probably about 30% of my patients that come to me who have been either diagnosed, like I said, with long COVID or something else, or Ehlers-Danlos, which is a connective tissue disorder, um, through simple clinical presentation. So no genetic testing, no muscle biopsy. They will come to me, and at the end of the day, the imaging shows that they have instability every time. I've never had a patient come through where I've done the imaging that, especially when they're pre-qualified based off of these factors that I just explained, where they don't have instability.
So how severe does the instability have to be before the fusion surgery is recommended?
That is a great question, and there's no discrete answer for that because, for example, last week I had probably the most unstable individual that I scanned that I've ever seen before, and she's upright and functional, just dis disabled to some extent. But if you would look at her and put her next to somebody else who has, a quarter or a third of the instability that she has, who is completely bedridden, it's hard to explain that. And so, for example, the average person that comes through, I would say, has a total, we call it an alteration of motion segment integrity. So the integrity of the motion segment, in this case, C1, C2, the two bones, it should have integrity, stability. And when you alter that, that means that there's excessive motion. And so the average person, I would say, has anywhere between 6 millimeters and maybe 11 millimeters of overhang to both sides combined when they do this motion. Well, this lady had 21.2 millimeters. So she had literally more than 2 centimeters of motion in excess of what she should have between C1 and C2. And she was still, let's call it functional. And so what I found is that I think that the missing link or the missing piece of information is that some people are genetically endowed with a large canal at the base of their skull, and then a small brainstem and spinal cord in relation to that diameter of the canal. And other people have, unfortunately, a smaller canal and a thicker brainstem and spinal cord, which means in relation, the tolerance for them to have some amount of excess motion is far less than somebody who's got a big canal and small neurology. Does that make sense?
Yes, yes, it does. It does.
So it becomes basically a factor of mathematics and physics. So big diameter, small neurology, you can tolerate a lot more instability, if you will. And then small canal, big neurology, you can tolerate way less.
Makes sense.
So
Makes
there's no direct correlation. You have to take more factors into play than just the numerical value of the instability.
Well, I can see why you're getting contacted by from people all over the world, but how how would people, Dr. B, reach out to you if they, as they're listening to this episode and they're hearing some of the things they're going, oh, my aunt or oh, my
Yep.
spouse, how would they reach out to you?
There's two ways. So I've got two sort of websites or platforms. One is the clinical one, and it is just whiplashclinic.com. And the contact information is all there. And the other one, which is usually what people by word of mouth use when somebody from somewhere else has told them about it. So they'll reach out to me from, like I said, Egypt or wherever, and that's drblaskovich.com. So that's drblaskovich.com. That's a way to, literally get straight to me without, running through reception. I do have an assistant helping me with this, but so she will funnel that information to me, but without having to go through the full clinical, protocol and pathway, then drblaskovich.com. But as far as making an appointment in person and coming to see me at either one of the clinics, it would be through whiplashclinic.com.
We'll put
And I
that.
and I'm an open book. I love communicating with patients from all over the world. And once people have, generally what happens is people send me their imaging. So if they're not able to come to me from wherever, let's say Tasmania, I've had someone, they will transfer me their imaging digitally over the internet. I will download the imaging. I will review their case history. I will review the imaging, look at all the imaging. I will annotate abnormalities that I see that, in my opinion, are relevant to their case history and their problem. And then I will set up a Zoom call with them like this to visually show them the findings. And then I'll share with them the file of annotated images. So with some advice potentially to maybe, knock on the door either of a physician or a physiotherapist or somebody in their local area where they're from to discuss this with them. And I always tell these people that I'm always open to having a discussion and a communication with whatever physician or whatever therapist that is that they end up taking this to, so that hopefully they can get a good result without actually having, to come over and see me.
Mhm.
Because it is possible. It's just a matter, like I said, of observation, education, and willingness.
And I'm sure you have patients that come.
I do. Yeah, no, there's patients that come and spend a couple weeks close to one of the facilities, and I generally end up treating them, 2, 3, 4 times a week for a couple weeks with this. And then I try to educate them on how to maintain doing this themselves. Because at the end of the day, for my own problem that, happened to me almost 30 years ago that I've been, mediating for the last 24 successfully, um, the treatment that I render to myself is the most effective, not only because I can feel best what, where the right spot is and what the right direction of pressure is, but because I can do it every day as many times as I need to. I don't have to depend on somebody to passively do it for me and make an appointment and wait. So I can literally hit the uh, hit the mouse right on the head as soon as I see him, peek his head out through the crack in the wall.
Right, right. Yeah,
And
that's
that keeps me in some level of neutral functioning.
well, that's so wonderful. Well, it's been a very enlightening discussion for me, and I know our listeners will as well. So, what would be one final takeaway that you could offer our listeners as we wrap up here today?
Well, if they're having these types of symptoms, and they're curious as to whether or not um, there may be some truth to them having an unstable upper spine, is for them to Google the term sharp purser test. And so this test is a test that someone like myself or a physiotherapist or anybody, if you have a family member who can, look at a diagram and try to make sense of it, would be able to do on somebody. And it's a reductionary test. So that means that if a person has, dizziness, blurry vision, heart palpitations, whatever, symptoms that they're feeling at that moment in time, like, pressure in their head, that if you conduct this simple test, which they do while they're sitting down, and it reduces their symptoms, then it would be strongly advisable to go get a motion x-ray to determine whether they have an unstable upper neck, because that'll put them on a much more directed path to improvement, or at least self-empowerment, so that they can be educated. Because when I first had this done on me back at the end of 2006, before I decided to, buy a machine in 2007, which unfortunately wasn't able to come into the Netherlands, um, I wish someone would have done that on me. Let's just put it that way. Or someone would have had the wherewithal to know to do that on me.
So how do you spell the sharp purser test? So I'll make sure I put it in the show notes properly.
Yeah, so sharp, just like a sharp knife, and
Uh-huh.
then purser, like you're pursing your lips, Purser.
Okay,
And
good.
all it really involves is putting pressure on the forehead with one hand, and a pincer grip like that on the spine of your second neck bone, and pushing them in opposite directions. And so what that does is actually recalibrates the canals on top of each other in case they are slightly shifted off center, putting pressure on the brainstem. So that should reduce the pressure on the brainstem, and like I said, reduce the symptoms. So it's not a provocative test; it's a reductionary test.
Well, that's wonderful, and thank you, thank you. This has been one of the most informative discussions I've had, and your episode will be probably between the 80s and 90s now. For 2 years, I've been doing this, and very informative, very enlightening. And I want to thank you again for being willing to share your expertise, your heart, your passion for helping people live full, healthy, and vital lives. That's wonderful.
It's a true pleasure, Mike. Thank you very much for having me.
And if you'd like to reach out to me, you can always go to mikebeverly.life. That's MikeBeverly.life. While there, you can hit the podcast tab to listen to this episode and many others in the library. There's some incredible blog posts about hydration recently there, because hydration is very important. I'm sure you would agree, Dr. B.
Absolutely.
Yeah, and what's interesting is it's probably more important in the winter months than it is the summer months.
It is. It is. And hydration with some mild salt water. Look that up.
That's wonderful. That's wonderful. So everyone, we'll look forward to having you back on another episode real soon of the Warriors of Well-Being. Have a wonderful rest of your day.